Welcome back, everyone. Today we'll discuss about gastrointestinal surgery. First, we talk about pathogenesis of gallstones. Remember, in order for the body not to form gallstones, it is the normal levels of cholesterol, normal levels of bile salts, and normal levels of phosphatidylcholine that are essential for the formation of biliary vessels and vesicles to remain unsaturated within the cholesterol. That is, the level of biliary vessels and the cholesterol will be normal when the levels of bile salts and phosphatidylcholine is normal. But because of the pathological process or whenever this physiological mechanism is disrupted, which can lead to increase in the cholesterol, decrease in the bile acids, and decrease in the phosphatidylcholine, lot of the cholesterol becomes saturated in the bile. So the bile becomes super saturated and cholesterol can act as a nidus, that is the center. So it will form aggregation of the calcium salts around the cholesterol stones and can also cause accumulation of the mucus, and it is also associated with the gallbladder hypomotility. Whenever all these things happen, there will be formation of cholesterol stones. Remember, in the question, it is the fat female 40 that is usually having a gallstones after having a fatty meal, all F's. Next, we will talk about bilirubin metabolism. Whenever there is bilirubin metabolism, it is the heme that can form biliverdin. Whenever the RBCs are broken down, the hemoglobin is dissociated into heme and globin. Whenever the heme is present freely, it is toxic. So, heme oxygenase is the enzyme that can convert heme to biliverdin. The heme to biliverdin conversion is done by heme oxygenase. The biliverdin is then converted to unconjugated bilirubin by biliverdin reductase. This unconjugated bilirubin enters into the liver and becomes conjugated with the help of glucuronide transferase. This conjugated bilirubin, with the help of bacterial dehydrogenase, forms urobilinogen in the intestine. This urobilinogen becomes stercobilin, and is excreted in the feces. Remember, in the question, whenever you find hyperbilirubinemia, first most important thing you'll have to do is it a conjugated bilirubin that is elevated or is it unconjugated bilirubin that is elevated? We already learned that the unconjugated bilirubin is mainly formed from heme. So remember, unconjugated bilirubin, whenever it is elevated, it is possibly because of the hemolysis. I also want you to understand there can also be medications that can cause reduced uptake and can cause unconjugated bilirubin to be increased. Remember, in the question, young male presenting with the asymptomatic on routine evaluation was found to have elevated levels of bilirubin with the normal liver function. It is the Gilbert syndrome that you will have to think of. Next, we talk about the elevation of conjugated bilirubin. Whenever in the question you find that the bilirubin is elevated, which is mainly conjugated, you will have to think of the liver enzyme pattern. What check the liver enzymes? How are the liver enzymes? Is it the AST that is elevated or ALT that is elevated or both AST and ALT that is elevated? Also think if the AST and ALT are normal, how is the ALP? That is how we get to a diagnosis of conjugated bilirubin with liver enzyme pattern. Remember, in patients who are admitted to the hospital, in patients who have shock, in patients who had a recent travel, in patients who are IV drug abusers, hepatitis is the most important thing or the diagnosis that I will have to remember. Patient with a history of travel with food poisoning, now presenting with raised bilirubin, now presenting with fatigue, fever, and yellowish. And now the patient has got raised AST, ALT with elevation of conjugated bilirubin. I will think of viral hepatitis, please. Very important cause of conjugated bilirubin that is elevated along with AST and ALT. Young female presenting with the background history of type 1 diabetes mellitus or hypothyroidism, now presenting with fatigue and on lab evaluation has got conjugated bilirubin and has also got AST and ALT, it is the autoimmune hepatitis until otherwise proved because it is associated with underlying autoimmune disorders. Young female patient, 18 year, recent breakup with the boyfriend, has got anxiety issues, now presented with so and so complaints, but on lab evaluation was found to have conjugated bilirubin that is increased and predominantly AST and ALT that is elevated. Think of paracetamol or toxin related hepatitis. Patient admitted to ITU was treated for hypotension. Now the patient has got a liver enzyme pattern where conjugated bilirubin is elevated, AST is elevated, ALT is elevated. It is the ischemic hepatitis until otherwise proved. I also want you to understand there will be massive elevation of AST and ALT in cases of ischemic hepatitis. Young male has got a background history of alcohol or has a binge drink of alcohol, now presenting with conjugated bilirubin and AST and ALT that is elevated. Think of alcohol hepatitis as one of the most important cause. Whenever there is a patient presenting with erectile dysfunction or cardiomyopathy or diabetes mellitus or neuropsychiatric symptoms, think of hemochromatosis as one of the most important differential diagnosis. And in hemochromatosis, it is the conjugated bilirubin that is elevated, and it is the liver enzyme pattern with the raised AST and ALT that is elevated, please. Next, we talk about hyperbilirubinemia, which is conjugated hyperbilirubinemia with the raised ALP. Whenever there is raised ALP, first most important thing is the patient pregnant? Because cholestasis of pregnancy is one of the most important causes for conjugated bilirubin to be rising and also predominantly elevate alkaline phosphatase. Whenever there is a middle-aged patient with pruritus, itching, and also got weight loss, it is the cholangiocarcinoma which can present with the elevated conjugated bilirubin and elevated ALP. Whenever there is a male patient, it is the primary sclerosing cholangitis associated with IBD and is associated with conjugated bilirubin and raised ALP. Whenever the patient is a female patient with the background of fatigue or asymptomatic and is now presenting with unconjugated bilirubin that is increased and ALP that is increased, it is primary biliary cirrhosis the patient has. Whenever in the question, if conjugated bilirubin is increased and if the patient has got AST, ALT, and ALP that is normal, you'll have to think of genetic causes that is Rota syndrome and Dubin-Johnson syndrome. Next, we talk about biliary atresia. Whenever I think of biliary atresia, it is the children that are most usually affected. The thing I remembered in biliary atresia is the treatment of biliary atresia is liver transplantation. Also, Kasai procedure is one of the most important management we'll do for biliary atresia. The name itself suggests that there is atresia of the biliary tract. So, whenever there is atresia of the biliary tract, patients usually are asymptomatic at birth. But the conjugated bilirubin usually builds up gradually, and the patient usually presents with hyperbilirubinemia, that is the jaundice, that is dark urine, and sometimes the patient can also have hepatomegaly at age less than 10 weeks. Whenever in the question you find the patient age less than 10 weeks with elevated hyperbilirubinemia and abnormal liver function test, you will have to think of biliary atresia as one of the most important differential diagnosis. Remember, the first most important investigation we do is a ultrasound. Whenever you do an ultrasound, it is an absent gallbladder that the patient has. The examiner will be kind enough to give you the ultrasound findings in the question. Remember, if there is a liver biopsy option, you can select the liver biopsy option because the liver biopsy will show bile duct proliferation, portal tract edema, and fibrosis. It is the fibrosis that I want you to remember for patients with biliary atresia. Whenever there is a gold standard diagnosis of biliary atresia, it is the bilirubin, it is the intraoperative cholangiography that you will have to select, please. The treatment is basically definitive treatment is liver transplantation for biliary atresia. Next, we talk about primary sclerosing cholangitis. We already discussed primary sclerosing cholangitis is associated with inflammatory bowel disease. Patients are usually asymptomatic. Patients will have increase in the ALP and also increase in the conjugated hyperbilirubin. Whenever you do a cholangiography, the examiner will give you as an option in one of the answers saying that this patient, what could be the findings on cholangiography? It is the dilation of intrahepatic or extrahepatic bile ducts that you will find in primary sclerosing cholangitis. Whenever there is primary sclerosing cholangitis, it is the sclerosing, it is the fibrosis of the internal organs. So on liver biopsy, you will find a onion skin pattern, please. Very important. It is very important to remember the complications of primary sclerosing cholangitis. In primary sclerosing cholangitis, the patient usually presents with fractures. Think of osteoporosis. The patient usually present with fat soluble vitamin deficiencies. The patient usually presents with the transition to malignancy, that is basically a cholangiocarcinoma that is usually seen. Remember, it is a fibrotic condition, so there can be complication of biliary stricture as well. Remember, any patient whom you diagnose primary sclerosing cholangitis, a colonoscopy must be done in all patients with a new diagnosis of primary sclerosing cholangitis. This is to rule out inflammatory bowel disorder, please, or inflammatory bowel disease. Whenever the patient has got primary sclerosing cholangitis with inflammatory bowel disease, it is the annual colonoscopies that you will have to do because these patients are at risk for colon cancer. Next, we talk about calculus cholecystitis. Calculus cholecystitis, the name itself suggests that there is inflammation of gallbladder because of a stone. Whenever there is a cystic duct obstruction because of the stone, it will pull up all the bile secretions. Whenever there is pulling up of bile secretions, this acts as a very good media for bacterial infections and there can be developing secondary bacterial infections. Remember, whenever there is calculus cholecystitis, it is the complications that is important. The patient can present with sepsis, the patient can present with the empyema of the gallbladder, or there can also be abscess. Remember, in all these conditions, in the question, you will find fever as one of the most important things. Now, talking about secondary bacterial infections, the most common bacteria we find is E. coli, Enterococcus. In alcoholics, it is the Klebsiella that is the most common organism. So, antibiotics must be given in patients with calculus cholecystitis, and it is a broad spectrum antibiotic. It is the piperacillin tazobactam that you will need to give. Remember, once the patient is off infection, then you will have to do a cholecystectomy, please. Next, we talk about acalculous cholecystitis. When we talk about acalculous cholecystitis, the name itself suggests that it is the inflammation of gallbladder because there is no stone. Why do patients develop acalculous cholecystitis? It is basically because the patient, when stressed with other medical conditions, the patients will develop acalculous cholecystitis. The classic examples you find in the question or the exam scenarios you find is basically patient will be having severe burns or severe trauma, or patient will be having pancreatitis, ARDS, or patient will be admitted in ITU, or the patient will be having a total parenteral nutrition, or there can be history of hemorrhage with shock. These are all the conditions where you will have to think of acalculous cholecystitis. The examiner will mention that there is an ultrasound which did not detect any gallstones. That is how you will have to think of acalculous cholecystitis, please. Very important. Remember, patients with post-operative days, acalculous cholecystitis is common. So all these things you will have to identify. It is the risk factors that you will have to remember in order to think of acalculous cholecystitis. But it is very easy. The examiner will tell you that the patient has got right upper quadrant pain, patient has got a temperature, but there is negative ultrasound with the history of ITU, burn, sepsis, pancreatitis, shock, TP, and fasting, and everything. That is when you'll have to think of acalculous cholecystitis. The complications for acalculous cholecystitis is important. It is the gangrene that I will remember. And the next most important thing is emphysematous cholecystitis. This cholecystitis could be possibly because of the bacteria. So antibiotics are the first initial step in the treatment of acalculous cholecystitis. Remember, when the patient is not responding to antibiotics, it is the cholecystostomy you will have to do. That is putting a drain through the skin into the gallbladder, that is percutaneous cholecystostomy. When the patient is stable and if the patient is not responding to percutaneous cholecystostomy, it is the cholecystectomy that we will have to do. Remember, the cholecystectomy in in acalculous cholecystitis is usually done to prevent emphysematous cholecystitis. The definitive investigation or the most favorite investigation for examiner for acalculous cholecystitis is the you will have to do a HEDA scan. What is HEDA scan? It is hepatobiliary iminoacetate acid scan. That is what you will have to do. Next, talking about the complication of acalculous cholecystitis, that is emphysematous cholecystitis. Emphysematous is nothing but air. That is the inflammation of the gallbladder associated with the air. When is the inflammation of the gallbladder that will happen and is associated with the air? It is basically because of the formation of the gas forming bacteria. The most common organisms are Clostridium and also E. coli. Whenever there is emphysematous cholecystitis, the patient can present with features of cholecystitis, but on the imaging, you will find gas in the gallbladder wall. Why is emphysematous cholecystitis an emergency medical condition? It is because there can be gangrene and there can also be perforation. Remember what happens whenever there is perforation. The character of the pain changes. Whenever in the question, the character of the pain changes, you will have to think of perforation, please. Very important. The patient can have change in the pain. The patient's pain is relieved suddenly, and now the patient has got guarding and rigidity of the abdomen. That is when you will have to think of perforation has happened and the patient is developing peritoneal signs. The most important diagnosis you do for emphysematous cholecystitis is doing a CT scan. In the CT scan, you will find an air fluid level that is usually seen or characteristic of emphysematous cholecystitis. There can also be gas which appears as black on the CT scan. Next, we talk about the treatment for emphysematous cholecystitis. Given that the complications of emphysematous cholecystitis are very high, we usually do an emergent cholecystectomy in patients with emphysematous cholecystitis, please. Very important. Next, we talk about the antibiotics. We usually give antibiotics, piperacillin and tazobactam after the treatment of after surgical treatment by emergent cholecystectomy, please. Remember, the most important differential diagnosis for emphysematous cholecystitis is basically a biliary enteric fistula. Whenever there is fistula, only if the fistula is infected, there will be fever. In patients with biliary enteric fistula, there is no fever. Remember that. That is very important. Next, we talk about estrogen induced gallstones. Not only estrogen helps in the formation of gallstones, it is also the progesterone that helps in the formation of gallstones. Whenever there is estrogen, estrogen increases the cholesterol secretions. That is how the gallstones are formed. Whenever there is progesterone, the progesterone usually decreases the bile acid secretion and also causes decreased gallbladder emptying. That is when you find the gallstones are formed. Remember, the most common scenarios usually asked is patient on OCPs, patient is pregnant, patient is using estrogen or hormone replacement therapy as well. This is how you will have to think of gallstones when the patient is presenting with abdominal pain, please. Next, we talk about management of gallstones. Whenever we talk about management of gallstones, it is basically based on the symptoms. You identify a patient with gallstones asymptomatically. Don't do anything. Send the patient home. If the patient has got symptoms of cholecystitis or colic, gallbladder colic or biliary colic, it is you will have to do a elective cholecystectomy. That is, you will have to schedule a date and then you will have to treat the gallstones. Remember, patients with complicated gallstone disease, such as patients developing complications secondary to gallstones, that is cholecystitis or choledocholitis, that is the gallstone in the cystic duct, or patient having gallstone pancreatitis. First, you will have to treat the condition, and then because the patient is developing cholecystitis, you will have to do cholecystectomy within 72 hours, please. Next, we talk about porcelain gallbladder. My favorite gallbladder is porcelain gallbladder because it can be identified on the CT as a rim which is calcified. So, calcified rim in the gallbladder with bile in the gallbladder, that is when you will have to think of porcelain gallbladder. Remember, the complication of porcelain gallbladder is usually asked. It is the adenocarcinoma the patients develop with porcelain gallbladder. So you will have to remove the gallbladder in order to prevent adenocarcinoma of gallbladder. That is, cholecystectomy must be done in patients with porcelain gallbladder. Next, we talk about post-cholecystectomy syndrome. Now, this patient has got gallbladder that is removed, but sometimes the patient presents with persistent abdominal pain. The patient also presents with nausea. Remember, whenever the patient presents with persistent abdominal pain after cholecystectomy, that is when you will have to think of post-cholecystectomy syndrome, please. Basically, the causes could be because of the stone that is retained, or there can be because of the slowness of the bile formation or slowness or accumulation of the bile that is happening. Remember, there can also be complications of the cholecystectomy. It could be because of the pancreatitis or any peptic ulcer disease that the patient has that can develop post-cholecystectomy syndrome. Remember, whenever there is post-cholecystectomy syndrome, it is the raised ALP that is usually seen. We do not know if there is any cause of the if there is any stone that is accumulated or if there is any biliary obstruction that is there. So on ultrasound, you will find that there is no gallbladder, but there is a dilated common bile duct. What did we study in gastroenterology in medicine for USMLE step 2? If there is dilated bile duct, the next most important investigation you do is ERCP. Remember, the patient with post-cholecystectomy syndrome can also be presenting with peptic ulcer disease. Sometimes, if the pain in the question is peptic ulcer disease, you will have to do a endoscopy as well, please. Remember that. So, how do you treat post-cholecystectomy syndrome? The causes for post-cholecystectomy syndrome are pancreatitis, slowness of the gallbladder, or dilated bile duct, or patient with peptic ulcer disease. So you'll have to treat the underlying cause in order to treat post-cholecystectomy syndrome. Next, we talk about acute cholecystitis. Remember, whenever there is acute cholecystitis, you will have to first treat the infections with piperacillin tazobactam in order to cover E. coli and Klebsiella, please. Very important. Next, we talk about bile acid diarrhea. Remember, the gallbladder is removed and the bile acids are entering into the intestine. Whenever the bile acids enter into the intestine, they are usually not reabsorbed properly. So, these bile acids go and enter into the large intestine, and this causes the mucosal irritation. Whenever there is irritation of the intestine overacts. So, it is the diarrhea that usually presents. It is usually seen in patients with post-cholecystectomy or patient who has got inflammation of the bowel. Whenever I say inflammation of the bowel, it is the inflammatory bowel disease that we are thinking of. Patient can also be receiving radiation for malignancy. Patient can also have an underlying malignancy, or patient can develop it as a complication of post radiation therapy as well. So bile acid diarrhea is one of the most common clinical scenario tested. I want you to understand that the bile acid diarrhea is basically a secretory diarrhea and the patient presents with abdominal cramps. There will be stool studies that are usually normal and does not show any source of infection. Whenever there is bile acid diarrhea, you will have to give agents that can reabsorb this bile. That is, the bile acid binding resins such as cholestyramine and cholestypol that are usually used in the treatment of bile acid diarrhea. Next, we talk about sphincter of OD dysfunction. Whenever there is sphincter of OD dysfunction, the clinical scenario in the question, there can be right upper quadrant pain or epigastric pain, which is recurrent, and there will be dilation of the common bile duct without any stones. That is when you will have to think of sphincter of OD dysfunction. Usually, sphincter of OD dysfunction patients will have history of pancreatitis, or there can also be an underlying surgery as well. That is when you'll have to think of sphincter of OD dysfunction. Whenever there is sphincter of OD dysfunction, it is the manometry that we will have to do because the pressure in the sphincter is increased. The sphincter pressure is increased. That is why you will have to treat the patient with sphincterotomy. Next, we will talk about co cholangiocarcinoma. When we talk about cholangiocarcinoma, the favorite picture I get in my mind is a 50-year-old female presenting with weight loss, pigmentation, dark urine, pruritus, raised ALP. That is when weight loss, that is when I will think of cholangiocarcinoma. It is basically associated with primary sclerosing cholangitis. Males will be associated with underlying ulcerative colitis. And usually in the question, it is the female patient. And the diagnosis is basically by uh, finding out the elevated increased carcinogenic carcinogenic embryonic antigen or increased CA 19-9, please. Very important. The diagnosis is basically made by CT scan and you can also do an ERCP. Next, we talk about hemobilia. It is nothing but it is the blood in the bile. That is what I call hemobilia. It is basically a rare cause of upper gastrointestinal bleeding. But remember, whenever you think of hemobilia, which is usually rarely asked, it is a complication of a procedure that is usually an endoscopy or a liver biopsy or an ERCP. That is what you'll have to remember. Whenever there is hemobilia, there can be right upper quadrant pain and there can also be bleeding, which is more prominent. So on lab test, you will find that the patient has got increased conjugated bilirubin and there will not be any involvement or elevation of the liver enzymes, but there can be upper gastrointestinal bleeding, there can be anemia, and there will be, if there is gastrointestinal bleeding that is going on, there can be sign of dehydration, that is the urea and creatinine will be elevated, please. Whenever there is a hemobilia and you will have to do a scan, please do a CT scan because CT scan can easily identify the fluid. That is what I will have to do. Next, most patients usually self-resolve, so do not do any overacting treatment for hemobilia, please. But remember, the diagnosis for hemobilia is very important. It is the post complications of a procedure with upper gastrointestinal bleed, where you find increased unconjugated bilirubin with anemia and with the AKI, that is when you'll have to think of hemobilia. Next, we talk about ischemic hepatitis. I also told you that these patients will be admitted to the ITU, has got a history of shock, sepsis, where there is systolic blood pressure of 60 by 40, and this causes ischemia of the liver. That is when you will have to think of ischemic hepatitis, please. It is basically because of the hypoperfusion of the liver that the patient develops. Remember, the aminotransferases will be elevated significantly, that is thousands in number, please. Whenever you treat the hypotension, the ischemic hepatitis will also be treated, and bilirubin, which is usually elevated, will be corrected as the hypotension is corrected and it becomes normal. Gilbert syndrome, there will be unconjugated bilirubin that is elevated, and there will be normal liver function tests, please. Next, we talk about portal vein thrombosis. My favorite question in exam scenarios is patient presenting with splenomegaly. Don't tell this to anyone. This is your clinching diagnosis. Patient presenting with splenomegaly has got portal vein thrombosis when the liver is involved. This is the most important diagnosis of portal vein thrombosis. Isolated splenomegaly can be seen in portal vein thrombosis. Cirrhosis with splenomegaly indicates portal hypertension. Patient developing with sudden abdominal pain with splenomegaly, background of cirrhosis, that is portal vein thrombosis until otherwise proved. Patient has got varices on endoscopy. This indicates that the patient has developed the portal hypertension. Whenever the patient has got portal hypertension, there can be splenomegaly. Whenever the patient has got abdominal pain, there can be portal vein thrombosis. Whenever the patient has got recurrent abdominal pain, background of splenomegaly, background of cirrhosis, then patient also has got a recurrent variceal bleeding. Please think of portal vein thrombosis as one of the most important causes of recurrent variceal bleeding. This is what I will have to remember for portal vein thrombosis. Next, we talk about screening in cirrhosis patients. Every 6 months, you will have to do an ultrasound at least in order to rule out the cancer, in order to rule out that the patient has not got a progression of cirrhosis. This is what I will have to remember. Whenever the patient has got new onset of ascites in cirrhosis patients, I will think of portal vein thrombosis or acute presentation of portal vein thrombosis, please. This is what I will have to remember. And annual or every 6 month screening must be done in order to rule out hepatocellular carcinoma or watch for hepatocellular carcinoma. Next, we'll talk about the differential diagnosis of solid masses in the liver. I'll send you a new link and then I'll see you there. Thank you very much.